Hi, in this video I wanted to look at how any defect in the sympathetic pathway controlling pupil size can lead to anisocoria, in particular small pupil. So if we look back to this diagram, which we've seen before in another video, which shows the sympathetic drive that controls the dilator pupillae. And it's worth noting that we always have some basal sympathetic drive that keeps our pupils a certain size, so from not preventing it from being too small. We always have some basal rates, but if you affect that pathway, then there'll be some apparent anisocoria and the pupil will seem smaller on the affected side. So let's go through the normal pathway to begin with. And the bits I'm circling, just the bits to pay attention to. So the sympathetic pathway begins at the hypothalamus. And that is where we have the first order neuron. So that goes from the hypothalamus all the way down to the ciliospinal center of Budge. Let's do that in a slightly smaller pen. So ciliospinal center of Budge is comprising the nerve roots C8 to T2. And then this synapses with the second order neuron, which goes over the apex of the lung and loops around the subclavian artery and synapses at the superior cervical ganglion. And that's located at the carotid bifurcation. And then the third order neuron ascends and follows the internal carotid artery in the carotid plexus, enters the nasociliary nerves, long ciliary nerve, and that innervates the pupil dilator. And also the Muller's muscle of the eyelid, so the pupil dilator and the Muller's muscle of the eyelids. So that's why we see the ptosis in Horner syndrome, because the Muller's muscle, which is the opposing muscle to the inferior tarsal muscle, which is on the lower eyelid, but this is on the upper eyelid, it's gonna, if there's a problem in the sympathetic pathway, the Muller's muscle isn't going to work as well. So you'll see an apparent ptosis, almost a droopy eyelid. So that's an overview, and we can. I'll just show you another diagram to show in case you want to see another diagram. So this is essentially says the same thing. So the first order neuron, the hypothalamus, the green, goes into the synapses in the spinal cord, loops around the subclavian artery over the apex of the lung, and then synapses again, superior cervical ganglion, and the third order neuron enters the nasociliary nerve and the long ciliary nerve to synapse at the end. And it's worth noting the structure of the iris. So this is from Morenegger's Clinical Anatomy. So the iris itself, we can give you some orientation. So this is the cornea. We've got the iris in the blue here. It's the iris itself. We've got the lens. And we've got some zonular fibers coming from the lens there. We've got the ciliary body with the ciliary muscle. And now onto the actual sphincter pupillae and dilator pupillae. So we've heard those names used a lot recently, and on the actual iris, it's worth noting what direction the fibers go in. So actually these fibers here coming out longitudinally, we call this would be the sphincter. Oh no, wrong. It's not the sphincter, completely wrong. It's the dilator pupillae. Crucial to get these right the way around. So these are longitudinal fibers, and these over here, these are the circular fibers, because imagine they're contracting in a circle. You can imagine it's going to make the pupil smaller. If you imagine the dilator pupil, if they contract along the fiber tension lines, then that's going to make the pupil bigger, because you're stretching from in to out. So back to here, so these are the circular fibers, and this is the sphincter pupillae. Excuse my writing. Okay, and we can see that we look at this diagram here, nope, this is also from Moore and Ager. So we have our sympathetic and parasympathetic pathways that go to either the sphincter pupillae or the dilator pupillae. So we said before, this is here. Now we've got a ganglion here. So that has got to mean that this pathway, must be the ciliary ganglion. So that means that this bottom diagram here, this bottom eye, that's showing the effects of the parasympathetic pathway on pupil size. So this is the parasympathetic pathway. So parasympathetic pathway. So if the light is shone into an eye, then it's going to activate the afferent pathway, etc., and then it's going to come from the endogoiphal nucleus. That's going to be, both those nuclei are going to be stimulated from the putectal nucleus, and that's going to stimulate the efferent pathway, and then eventually we're going to get a constriction because the ciliary ganglion parasympathetic pathway innervates the circular muscle, the sphincter pupillae, and that's these inner circular fibers. Now that's in a bright room, in a dim room, in dim light. There's no ganglion here, so this must be the third order neuron. Let's do that different. Oh, that's gone wrong. Okay, so this is going to be the third order neuron for the sympathetic pathway. And you can see these fibers is innervating the longitudinal muscle, the dilator pupillae. So that gives you an overview of iris function and those two muscles in a bit more detail. So one of the main causes of a small unilateral pupil, an anisocoria affecting the sympathetic pathway, is Horner syndrome. So Horner syndrome usually presents with a classic triad, although actually a third of cases there is no determined cause, but so we call it a syndrome. So the syndrome is a collection of symptoms, and the three main symptoms that you may see is a unilateral facial anhidrosis, which is a lack of sweating on one side of the face, partial ptosis. You can see in this man here, it's got a partial ptosis in this left eye, and a myotic pupil, so a small pupil. And you can see here, notice the difference that this pupil on the left is much smaller than this pupil on the right. So those are the three main symptoms, and actually you might see more depending on the actual cause of the Horner syndrome. So Horner syndrome isn't a disease, it's a syndrome. So there may be an underlying cause that you have to look for, and that's really important because if a patient is, for example, complaining of a recurrent cough and hemoptysis, then you're worried about a lung cancer, and actually maybe that could be affecting the sympathetic pathway, compressing on the sympathetic chain and producing the syndrome. So always thinking about an underlying cause to the syndrome is really important. So I've divided the causes of Horner syndrome into three main areas. You can see here. So the three main areas, we can look at it by neuron. So remember we said the sympathetic pathway is a 3-neuron pathway. So you got first order neuron, second order, and the third order neuron. If we look at the first order neuron, well, where's that going from? The first order neuron is going from, we said, from the hypothalamus to the ciliospinal center of Budge. So any lesion along that pathway is going to produce some defect. So a few causes could be a stroke, could be multiple sclerosis, meningitis, or a tumor, and that could compress one side of the sympathetic chain, and that could produce symptoms on that side of Horner syndrome. The second order neuron path, well, where's the path from? The second order path is from the ciliospinal center of Budge. It's going to go over the apex of the lung, under the subclavian artery, and silence of the superior ganglion anterior carotid bifurcation. So I've got a few causes here. Could be a lung cancer, Pancoast tumor, and this is what's Pancoast tumor is over here. This is taken from the British Medical Journal from a case report. So you can see here they've circled quite nicely where the pancreas tumour might be. And there's a sympathetic chain running posteriorly to that. So if you compress that, that's going to produce the symptoms of a Horner syndrome. What have we got next? We've got cervical rib. So cervical rib we classically see in young women who've got a congenital abnormality, an extra rib on one side. You can see here from this X-ray, it looks quite obvious. So you can see on here on the left, they've got a cervical rib. There's an extra rib on this side, and it often comes from the C7 vertebra. So that can produce what we call thoracic outlet syndrome, where it produces symptoms in the arms, symptoms of numbness in the arms. But also, if it compresses on the chain, then you can get Horner syndrome. Next, we've got subclavian artery aneurysm. Subclavian artery aneurysm. Here with my cursor, that's where the aneurysm is. So really close to sympathetic fibers. If you've got a compression there, again, leads to Horner syndrome. And lastly, I've just put iatrogenic nerve damage. So, for example, in surgeries, if thyroidectomies, for example, or a tonsillectomy, if you sever important nerves nearby, that can include sympathetic fibers to the eye, so that can potentially affect it as well. And the last collection of causes, for Horner syndrome could be in the third order neuron. So the third order neuron, where does that run from? The third order neuron runs from the superior cervical ganglion, on the internal carotid artery, on the nasociliary long ciliary nerve, and to the pupil dilator, multiple ciliary eyelids. So that can include, for example, internal carotid artery aneurysm, temporal arteritis, so giant cell arteritis, and you want to be, if the patient is complaining of pain, neck pain, or pain on jaw claudication, you want to be worried about that, and you probably want to investigate. You might want to do a temporal artery biopsy, for example. And herpes simplex infection anywhere along that route can also cause a Horner syndrome. So we talked about some of the causes. We talked about how if you affect a sympathetic pathway, that can lead to a myocyte pupil and a partial ptosis. How could it lead to a unilateral facial anhidrosis, or a lack of sweating on one side? Well, it depends on where. You might not always see that. So it depends on where the actual problem is, whether it's before the carotid plexus or after the carotid plexus. If we look back at this diagram here, we can see that at the end of the second order neuron, synapse is the superior curved cervical ganglion. Now you've got fibers, sweat fibers called pseudomotor fibers. You can say pseudomotor. They can branch off and they can go supply the face, the upper and lower face. So you may only see, depending on where the problem is, you may only see sweating on one side on the forehead. You may see only unilateral sweating on the whole side of that face. Lack of sweating on the whole side of the face. So it depends, but that's what you can see, that the pseudomotor fibers do branch away at some point, and you may not always see the lack of sweating on one side. One final thing to note, so we've looked at how you can get sympathetic causes that can lead to a Horner syndrome. Another thing worth noting is the pharmacological causes. One of the main ones is pilocarpine. So pilocarpine is an M3 receptor agonist. So it's M3 receptor agonist, and pilocarpine is often used for treating raised intraocular pressure because it has effects on the ciliary body and the trabecular network to allow draining of aqueous humor. But pilocarpine acts on the M3 receptor, acts on the M3 receptors to stimulate pupil constriction. So it stimulates that parasympathetic pathway. So if you put pilocarpine eye drops, it will cause constriction of the pupil, and that can lead to anisocoria. So if you were to only put drops in one eye and then look at both eyes, you'd see that the drops that you put in the eye would be considerably smaller. So that's one example of a pharmacological effect on pupil size to give an apparent anisocoria. So I hope that gives you a good overview for Horner syndrome and anisocoria and the small pupil.